last 10 years now. And every time I think that I should stop doing it, but then I realize that I must keep on doing it. That is the reason, because this is a forgotten art. I don't know why it is forgotten. I know it is difficult, it is time consuming, but once you get into doing it, it takes very less time to do it, and you can get a lot of information about it. Just to give you an example, I'm going slow because we don't have one speaker, so there's plenty of time. 3-4 days ago, I got a patient from Karachi. One of the surgeons referred to me just for routine checkup. She had a phaco done on a complicated eye, and he mentioned that she had KPs and mid-dilated pupil and some transillumination. When I saw the patient, she rather had pigment on the surface of the lens. And when I did the gonioscopy, I found Symposium line, which I had not seen for many months. So the diagnosis became very, very clear. So it is difficult, I realize, and it is time consuming. So this presentation is about why to do gonioscopy, what are the principles, what is the method, and what are the angle structures and how we grade them and key points. See, nowadays gonioscopy has become very easy because of the availability of new type of lenses, and they are very convenient to apply on the eye, and they do not require too much time as before. And why should we do it anyway? I didn't need to perform a gonioscopy. It's a fundamental part of any, at least if not ophthalmological examination, at least glaucoma suspect or glaucoma patient. Most factors in correct diagnosis is omission and then misdiagnosis is done initially for all glaucoma patients and suspects. Repeated periodically. It doesn't mean that once you've done it for good. No. It should be done periodically, maybe in 6 months, maybe in a year. And you should differentiate between a angle closure and occludable angle, and it's very important to differentiate it from a secondary glaucoma. So it can differentiate between a primary open angle glaucoma and an angle closure glaucoma, diagnose congenital glaucomas, secondary glaucomas, angle recession glaucomas. You'll be, when you get into habit of doing gonioscopy, you'll be surprised to one day find a patient, a young patient who has got unexplained unilateral glaucoma, and then you do the gonioscopy and immediately you see that there's something wrong with the angle, and that is an angle recession. Uveitic glaucoma is becoming very common these days as we are advancing in the diagnosis of uveitis. Neovascular glaucoma, of course, everybody knows, and iridocorneal syndromes. Tumors of the anterior segment can be seen cyclodialysis, cleft, intraocular foreign bodies, early detection of KF rings, and unusual cases of glaucoma, which cannot be solved by any. And to perform ALT, if you want to master performing an ALT, you should know. If you want to do a SLT, you should know gonioscopy, laser iridoplasty, laser cyclophotocoagulation, PI for a simple angle closure glaucoma. After trabeculectomy, if you want to see if there is a incarceration of the vitreous. Indentation gonioscopy can be used to break an acute attack of angle closure, and it gives you the anatomy of the angle as well. How do we do it? There are direct methods and there are indirect methods. And indirect is without indentation, and there is one indentation. You can see in the picture without indentation how the angle looks like, and with indentation how it opens up. These are the different lenses that we can use. Specialized lenses are available, but they're very expensive. But you can use only your simple 3 mirror, which is present in every eye clinic. Every eye surgeon has got it. And then you can just keep rotating it, and you can do a gonioscopy. If you are a glaucoma surgeon, you can buy good fancy lenses with different angles. So direct gonioscopy there are many advantages. This is a picture from a goniotomy operation theatre patient. You can see the OSP lens has been applied. It is straight on view, angle of visualization is variable, more panoramic, angle recession and comparison can be done. Disadvantage is very inconvenient. If you ever seen a goniotomy, the patient has to be positioned, the lens has to be positioned and special equipment is needed. Now in an indirect gonioscopy, simple thing for the residents, the slit lamp should be aligned properly with the outer canthus. You can take a simple 3 mirror or you can take a specialized lens, a Zeiss lens which is a Vogue 4 mirror lens or Zeiss lens, and slit lamp technique can be used. This is a lens that I use most of the time, which is very good for indentation. You do a good magnification of the slit lamp. This is the basic technique. Keep the lower lid down, explain to the patient, just go and apply. You don't need a coupling fluid there. And the edge of the prism looks up, and then you can do the gonioscopy. You must rest your hand on a proper hand rest, and you should be comfortable yourself. First do external examination, don't do anything else. You see, don't start doing the intraocular pressure. Do the intraocular pressure first and then do the gonioscopy, otherwise you will have problems. Tonometry before gonio, use local anesthesia, pay attention to patient's comfort, use good magnification and 2/3 of the beam and a semi-dark room. This is an ordinary 3 mirror, everybody has got it. You can use a coupling fluid there and then start seeing the angle and keep rotating the lens. And this is under high magnification. You can see you need to see about 30 to 40 angles to get used to the anatomy of the angle. Then you go to the top mirror and keep rotating the lens. And when you want to remove it, just press the eye with the other finger and it just comes out. Indirect advantages preferred by most: quick, convenient, no special equipment, can create corneal wedge, allows differentiation of appositional and sanical angle. Disadvantage: mirror image can be confusing. You're looking at 6 o'clock by 12 o'clock mirror. Inadvertent pressure on the cornea exaggerates the degree of narrowing in the Goldman lens, opens the angle in 4 mirror lens. When this covers the recognizing angle structures, when the iris covers the trabecular meshwork, it is very easy to mistake the non-pigmented trabecular meshwork for the scleral spur and a pigmented Chauvet's line for the trabecular meshwork. Indentation gonioscopy, you can see when you do that, you start seeing the structures. Now this is a video that will help you. Keep looking on both sides of the videos. It is showing the structures on one hand and scleral spur you can see there. This is a slow video, so you pigmented trabecular meshwork. That is where you are going to hit when you do an ALT. You must know how to recognize that. This is a non-pigmented trabecular meshwork. If you keep hitting it, the ALT is not going to work. And that is the Chauvet's line. And the corneal wedge can be seen on top. Then that is the cornea there. So this is a diagrammatic, that is the corneal wedge, diagrammatic representation of the. This is a normal angle under high magnification. You will see that I keep rotating the lens, and you can, it just needs a bit of practice, you know. जो झिझक होती है थोड़ी सी वो निकल जाए, मुझे भी शुरू में बहुत होती थी कि इस टाइम कंज्यूमिंग पर्टिकुलरली प्राइवेट पेशेंट्स में उन्हें समझाना पड़ता है सारा. इट्स ए नॉर्मल पिगमेंटेड एंगल. हमारे एंगल बहुत पिगमेंटेड होते हैं हमारे पाकिस्तान में, और ओल्ड एज में. नाउ दिस इज एवरीथिंग इज लेबल्ड हियर for your convenience. Ciliary body face, scleral spur, slightly depigmented, trabecular meshwork, then Symposium line. This is pathological in pseudoexfoliation and pigment dispersion syndrome. So with age, 6 o'clock is quite pigmented as compared to the others, and it is also pigmented in pathologies like pigment dispersion and pseudoexfoliation. Keep rotating the lens, and then you see all the structures and keep explaining to the patient, then it becomes very easy. This is high magnification. This is again a diagrammatic representation and just reminds you of different structures there. Now this is, everybody can classify the angles. Schaeffer की classification है, Spaeth की classification है. We usually follow Schaeffer's classification. Grade 4 is 40 degrees open, grade 3 is 30, grade 2 is 20, and grade 1 is 10. These are the different gonioscopic pictures of angles. Closed angle in the bottom left, open angle at top, open angle in the right hand corner, and peripheral anterior synecdoche. They are there. You can recognize them. You can see a foreign body there. You can see new vessels there, and you can see microhyphema after trauma if it's not seen in the anterior chamber. This is a very interesting video. This is automated gonioscopy. You don't need to touch the patient. Manufactured by, this is Professor Nadim's video. This is by Nidec. Now this is available in the market. This takes, it has got its limitation, लेकिन it is very, very useful. दोबारा देखने से, it shows you all the structures of the angle, and normal angles are very easy to exclude and see in this. This has got some other features as well. This is my angle. This is my own video of the same Nidec gonioscopy. There is no touch. You don't need to touch the patient. So, fundamental part of ophthalmic evaluation. It's almost the last slide. Confirmation of normal angle structure, determination of narrowness of closure of AC angle, grading of angle width, pathological findings can be seen and needs to be performed at least by a glaucoma surgeon. So, perceptions of training in gonioscopy. The study which highlighted, I did not copy the study but just the theme, ophthalmology trainees' dissatisfaction in the current gonioscopic training curriculum and a lack of confidence in performing the procedure. Appropriate modifications to the ophthalmology specialty training program could enhance trainees' gonioscopy learning experience. And I will request Mahmood, as he is designing with other professors the curriculum of glaucoma for the FCPS, and Professor Nadeem, he is also doing it, and Mahfouz, to take interest in this and make it part of the training and routine practice. Because झिझक बहुत होती है, मुझे भी थी, अभी तक होती है. At times you're in a hurry, you're not sure, you don't know what to do, but there's a lot of information that you can get. Thank you.
Any comments, questions?
मेरा एक्सपीरियंस है ये फाइंडो में वो ये था कि झिझक भी है. इससे ज़्यादा एक और चीज़ है कि जो रेजिडेंट्स होते हैं ना या for that matter even ophthalmologists, they presume that if the eye is white then the angle is probably open, so there is no need to do the gonioscopy, especially if you have to see 100 patients. तो वो भी झिझक भी है, लेकिन ज़्यादा एलिमेंट ये भी है कि वो presume है कि अगर आई white है तो बस एंगल ऊपर ही.
Nice. हाँ, जाहिर आपको
बस ये ऊपर चलो, ये निकालो, ये लाहौर ऑफ थैल्मो 2020 में खोलो ना, इसको खोलें ना पूरे को, पूरा को फोल्डर कॉपी कर रहे हैं आप, सिर्फ पहले फोल्डर को खोलें. क्या कर रहे हैं यार, फोल्डर नहीं खोला आपने, कॉपी की कमांड दे दी. फोल्डर को खोलो, हाँ खोलो. अब ये खोलो, ये हाँ हाँ कौन सा है इसका?
डॉक्टर महमूद आप कर लें अगर
नहीं महमूद साहब कर लें, मैं इधर से इस ये करो, खोलो इसको, ये खोलिए। इसको कॉपी कर लें, सेव कर लें। महमूद आपकी लोडेड है? और ठीक है, आ जाए फिर, कोई बात नहीं, इसको मिनिमाइज़ कर दो। ठीक, और ये निकाल लो, करें।
पॉइंटर है ठीक। बिस्मिल्लाह। ग्लासेस सर आप सर ग्लासेस आप Bismillahirrahmanirrahim. So I have named this presentation as visual field interpretation at a glance. Usually in the past few decades, especially after the advent of optical coherence tomography, we in clinical practice are becoming more and more inclined towards advising optical OCT for routine workup and diagnosis and monitoring of our patients. And of course, it has a great role in the diagnosis of glaucoma. But visual fields, I think we are a bit reluctant in using this investigation, although it is a part of definition of glaucoma, and because it is a test which is of subjective nature, so there are chances that the patient has some learning curve, or some patient might not be able to perform this test even after many tests. And but believe me, whenever you get a reliable test, it gives very important information about the disease. And OCT, the results of OCT are adjusted only for the age, but visual field results are not only adjusted for the age, they are also adjusted for the generalized depression or elevation in the hill of vision due to other conditions. And some retrogeniculate lesions might not be picked up by OCT test, while if the lesion is retrogeniculate, then we might be able to pick it up with visual field test. So usually there is no text in my slides, and I will only be discussing the field. So just at a glance, by just looking at the grade scales of these three tests, usually we have three types of tests we advise in glaucoma: visual field 30-2, visual field 24-2, and visual field 10-2. By just looking at the gray scales, we can see that which type of test we are seeing. Now the visual field 10-2 and 30-2, the gray scales of both these tests is circular, because these these investigation tests equal or degrees of visual field around the fixation. In 10-2, 10 degrees around the fixation. In 30-2, 30 degree around the fixation. The 24-2 gray scale is not circular, it is on one side conical, because on nasal side it is testing 30 degrees two additional points are added on the nasal side in order to see the nasal step, which might be missed if it also investigates 24 degrees on nasal side. Now the visual field test is divided into 10 parts, and the first part is the information about the patient and his eye and when the test was performed. So whenever you are interpreting or seeing the test, make sure that you are evaluating the test of the right patient. Sometimes patients have 2 or 3 family members of glaucoma, and all the tests are in the same file. So make sure you are evaluating the test of the same patient you are examining. Then other parameters are entered in the test, like the refractive error, visual acuity, and the strategies used for the test. The number 2 part of the test is about the reliability indices. There are 3 types of reliability indices: fixation losses, false negatives, and false positives. So if the patient is clicking at a very fast rate, its rate is more fast than the frequency with which the stimulus is presented, it results in false positive. And when the patient is initially attentive, but after some minutes he loses his attention, then this results in false negative error. And if the patient is moving his eyes, then this results in fixation losses. The part 3 is the numerical scale. In 24-2, the visual field, the 24 degrees of the test are tested with 54 points, 13 points in each quadrant. Here too, I already told that there are 2 additional points are added in the nasal quadrant. So these are 54 points. So numerical scale gives us information about the visual field, and each of these tests, the threshold recorded in decibels is written on it. Here we can see that threshold was less than 0. Now the brightest stimulus that the visual field test shows is 0 decibel, and the dimmest is in Humphrey, it is 40 or 50 decibels. If the patient is unable to see a stimulus which is of 0 decibel, this means that even the brightest stimulus, the patient was unable to pick that stimulus and was not responded. Similarly, here we can see there is a point in which the sensitivity was determined as 23 decibel. So in these points, relatively lighter stimulus was appreciated by the patient. Then this is the gray scale, which is generated from this numerical scale, and we can see that those points in which there is depression in the field, these are colored as more gray, more darker gray shade, and at those points in which the sensitivity is relatively better or normal, these are shaded in lighter gray tones. Then this is the total deviation plot. This plot is generated from this plot. What is done is that this corrects these, adjusts these results for age-matched normative database. So what does this mean? That here we can see there are minus 21, minus 28. So each this point shows that how much the corresponding point is elevated or reduced from its age-matched normative database. So here we can see it is minus 27, I think it is. So, and here the sensitivity recorded was 5 decibel. So this point is depressed from its age-matched normative database by 27 decibels. So actually at this point the sensitivity should be 32 decibels. Same is for each of these points. The deviation from age-matched normative database is mentioned here. And this is the grayscale for this total deviation plot. The points which are depressed at more than, which are more significant are colored more darker boxes, while the points which are significant but not to the greater extent, these are mentioned in p value less than 0.5 degrees, p value less than 2 degrees, etc. Then this is the pattern deviation plot, and this plot again extracted from this plot. What is done is that after plotting the total deviation plot, these results are again adjusted according to hill of vision of the patient. We know that glaucoma is mostly seen in old age patients, and in these patients there are other diseases also like corneal haze, cataract, refractive errors, or sometimes amblyopia. So these conditions result in diffuse depression in the hill of the vision. So in order to, because in glaucoma we are particularly looking at the focal defects, so in order to find those localized defects, first thing is to bring this hill of vision to the normal level. So that if the hill of vision of the patient is depressed, then the machine or the software adds some correction factors to bring it to the normal level, and then we are able to pick up the localized field defects. So here we can see that initially it was minus 27, and then after adjusting for the depression in the hill of vision, the result was minus 22. So the software added +5 to all these readings, and then this was again plotted, and in this way those defects which are due to the generalized depression in the hill of vision, those are removed, and only localized field defects, they have become prominent along with the p values which are mentioned in the part 8. Now I will be showing this is how this pattern deviation plot is generated from total deviation plot. The readings on the total deviation plot, these are arranged in a chronological order, and then the 7th reading is picked up by the test and it corrects this to 0. So here it was minus 5 decibel. The test applies a correction factor of +5 to make it 0, and then +5 is added to all these readings from here to here, and then the test the plot is again made. So, and this is the glaucoma hemifield test, in which the cluster of points in the superior hemifield are matched against the inferior hemifield, and the results are generated. Now some printouts of various patients, and at a glance we will try to find out what was the pathology. Here we can see that the gray scale and the total deviation plot, they are more darker as compared to the pattern deviation plot. So this occurs, of course we are considering that the reliability indices suppose are within normal limit. So whenever we see this condition that the gray scale and total deviation plot, they are more darker as compared to the total deviation pattern deviation plot, this means that there is more generalized depression in the hill of vision as compared to the condition that result in localized field defects. The test also writes here as generalized depression in sensitivity. So this occurs when there is significant refractive error of the patient, or cataract or diffuse corneal haze, which results in the generalized depression in the field. Here we can see that the refractive error of the patient was +6, as a result of which whole of the field was depressed. But when this was corrected for this depression in the hill of vision, the pattern deviation plot showed that only few points which had depression in the sensitivity. Again, there is another field here, something which is very quite unusual, that the gray scale and the total deviation plot seem normal, while the pattern deviation plot, there are more points with significant deviation, which is quite unusual, because there is no such logically no condition which results in such an elevation in the hill of vision that after correction for it all the field becomes depressed. So what was the reason? Actually there are abnormally high sensitivity was recorded because of these false positive errors. The patient was a clicker happy patient, as a result of which the sensitivity recorded at most of the points was higher than the normal. This was falsely high, and when the patient corrected it, then all the readings were depressed, and as a result of which whole of the pattern deviation plot was depressed. So we have to tell the patient that what mistake he made, and also tell the perimetrist that what instructions should be given to the patient next time in order to get a reliable test. Then this is another field in which we see that the grayscale, the total deviation plot and the pattern deviation plot, they are more or less giving the same picture. This occurs when there are less there are no conditions that are resulting in generalized depression in the hill of vision. For example, a patient who has a clear media, no refractive error, and he is just having some condition which resulted in the localized field defects. So as a result, in these patients we will see the grayscale, the total deviation plot and the pattern deviation plot are of the same shape. Here again almost similar, we can see similar thing, but the game is not over. If we see such a patient in which all these plots are similar in shape, then the diagnosis is still not confirmed. Again go back to the disc and confirm whether these results correlate with your own clinical findings, with the clinical look of the disc or the OCT. If these are not corresponding to each other, then there is something wrong either with your own assessment of the clinical picture of the disc, or something is wrong with the visual field test. So you have also to correlate these tests with the clinical picture of the patient. Like in this patient, there was a field defect which was noted here near to the fixation, and when the OCT was performed, the corresponding area showed the loss of ganglion cells. Then another condition in which we see a tunnel vision, here we will get a grayscale and total deviation plot, but in these cases in which there is extreme visual field loss, we will not get the pattern deviation plot, and we will have to rely either on these two things, or the other thing which is better in such cases is to shift this patient to 10-2 for next test, because if you again advise this patient for 30-2 test, now lot of time will be wasted on checking these points which we know that these are already dark. So better is to shift this patient to 10-2, which will result in less time consuming, and another advantage is that in 24-2 or 30-2 test, only 16 points are checked in the these 6 and 12 points are checked in the central 10 degrees, while the 10-2 test will check 68 points in the 10 degrees. So more closely we will be able to monitor this condition more closely in future. Last two tests, here we see this is quite common, and we know that this is a clover leaf pattern which is seen in cases in which there are high false negative. What happens is that initially the test stimulus is presented here and the patient is attentive. Then as the test progresses, the patient loses attention, as a result of which these outer areas become dark, and when the test is again presented in these points, the patient is unable to appreciate. So this, whenever you see a clover leaf pattern, at a glance you should be able to pick up that this is a test with high false negative results, and you have to tell the patient that something is wrong and you have to perform this test again in order to get a reliable test. Now what is this? You can appreciate 4 points here, paracentral points, and this is actually the reverse of this. This is called reverse clover leaf pattern. And when this reverse clover leaf pattern occurs, when the patient initially does not recognize that the test has started. So the initial, for few seconds, the patient does not recognize that the test has started, so he will not respond on these points. And after few moments, when he will recognize that the test has started, then he will start performing the test, and the rest of the field will be better as compared to these points. So this is again the reverse of this clover leaf pattern, and this is called the reverse clover leaf pattern. Again, you have to test this, perform this test again, and tell the patient that this what mistake was done. And you have also have to tell the perimetrist that what information was lacking when you told the patient how to perform the test. This is the last test, in which we see that there is a dark spot here similar to blind spot, and see what the test is suggesting. Fixation losses 19 out of 21, but rest of the test seems normal. So what was the mistake actually? The mistake here was that the blind spot was not plotted accurately, as a result of which when the machine showed the stimulus at the blind spot, that blind spot was not the blind spot of the patient, that part was the normal part of the patient. This actually occurs because there are two fixation points in the visual field machine. When we are checking the sensitivity of fovea, then the fixation for that test is different from the fixation point for which is used to check the rest of the field. Sometimes the patient fixates on the fixation point for checking the sensitivity of the fovea. In that case, whole of the field is shifts below, and as a result of which, when the point at the blind spot will be picked up by the patient, the machine will mention it as fixation losses. So in this case, again, you have to repeat the test and tell the patient that while performing the test, you have to move your fixation to the other point which is used to check the visual field of the patient. So these were the references that were used for this presentation. If there is any question from the audience, then we can answer.
जो आपने threshold pattern दिखाए थे, ये H2 या 24 ये 2 से क्या मतलब है? 2 आप एक तो disease around fixation
जी
ये 2 आपने explain किया.
हाँ अच्छा 10 your question is that what is 10-1 and 10-2 and 30-1 and 30-2, what I understand. In 30-2 or 10-2, the starting points are on these vertical and horizontal meridians. Here you see that the horizontal and the starting points are not on these horizontal and vertical meridians, but these are at offset of 6 degrees, 3 degrees here and 3 degrees here. Okay, this is 30-2. If it is 30-1 test or 10-1 test, then the starting point will be on these horizontal and vertical lines, and then the next point will be 6 degrees away from it. Then again 6 degrees away in 30-2 test. In 10-2 test, the next point is 2 degrees away. This is actually 30-2 is preferred. Sorry.
अगर लाइन के ऊपर आप रखते हैं तो वो 1 है, क्योंकि आपने 1 मान लिया. और अगर लाइन के दोनों तरफ 3 डिग्री के गैप से रखते हैं तो उसको 2 कहते हैं.
दोनों इसका एडवांटेज ये होता है कि अगर हम स्टार्टिंग पॉइंट्स ले लेंगे हॉरिजॉन्टल और वर्टिकल मिड लाइन पे, तो एक एक पॉइंट तो इधर चेक हो जाएगा, उसके बाद अगला पॉइंट होगा 6 डिग्री पे और उससे अगला पॉइंट होगा 12 डिग्री पे. तो बीच में जो 10 डिग्रीज के टोटल पॉइंट बचेंगे वो 1 2 ये वो कम होंगे. इस तरह जो है पॉइंट्स 12 बनते हैं, उस तरह 8 पॉइंट. तो हमारे पास ज़्यादा पॉइंट्स होते हैं जिसमें हम सेंट्रल 10 डिग्रीज को एवेल्युएट कर सकते हैं विद 10-2. हाँ जी, जैसे कि एज आई मेंशन्ड अर्लियर दैट अनदर एडवांटेज ऑफ परफॉर्मिंग विजुअल फील्ड टेस्ट इन आवर पेशेंट इज दैट OCT might be unable to pick up the defects which are retrogeniculate, the second order neurons or at the occipital cortex. But the visual field test will be able to pick up those defects also which are retrogeniculate due to lesion in the retrogeniculate part of the uh, uh, visual pathway. So the difference between the neurological and the glaucomatous field defect, we know that the neurological field defects, they respect the vertical midline, while the glaucomatous field defects, they respect the horizontal midline. So the field defects from superiorly, that will not extend to this inferior hemifield because of the arrangement of retinal nerve fibers. The arrangement of retinal nerve fiber layer, we know that here is the papillomacular bundle, then the superior arcuate fibers come like this, inferior arcuate fibers come like this, and then there are temporal fibers which come like this. The only field defects which glaucomatous field defect which does not respect the horizontal meridian is the temporal wedge, because temporal wedge can extend from superior to inferior hemifield because of the arrangement of the nerve fibers. These are arranged like a wedge. So again the field defect will also be in the form of a wedge, and that field defect can cross the horizontal midline.
Dr. Rahul, it's a very wonderful presentation. My question is, what is your cutoff point that this field, visual field is not reliable? For instance, if it's a fixation loss, how much you consider that this is not reliable? If it is, the other one is false positive or false negative.
The classical teaching in books or the which we read in the books is, for Humphrey it is mentioned as fixation losses of 15% and the false positive and false negative 25%. But this is not tested on the clinical trials, and we glaucoma consultants and you are deal with glaucoma patients know that even small numbers of fixation losses or small number of false positive and false negative can totally change the field. So we recommend it near to zero. Anything that is 2, 3, of course if the patient has very limited vision, 636, 660, in those patients it is expected to have some disturbed parameters, but the recommendations of 15%, 25%, 25%, these are not by the clinicians, these are by the manufacturers and vendors who say this cutoff point. And another thing is that false negative can be slightly higher even if the patient is attentive or is performing test with interest in cases of advanced glaucoma, because it is happens in advanced glaucoma that sensitivity is noted at a point, and after some time patient might not be able to pick or respond to a stimulus that is slightly higher than that. But false positive and false fixation losses, even small numbers of these can affect the test, and these are more indicative of unreliable test, because fixation losses means patient is moving his eyes. And how false positive is possible, that there is no stimulus and the patient is clicking, this can't be explained logically. So I think near to zero or keep it to minimum. These keep your threshold to minimum, not the one that is written in the books of 15% and 25%.
When you suspect some neurological disease and you want to do visual fields for them, which you will rely on the first question that this particular pattern will be tested right?
Mostly we perform 30-2 or 60-4 in neurological cases. For glaucoma, as I have already mentioned, 24-2 and 30-2 give almost same information. 24-2 test is relatively less time consuming, but in advanced cases of glaucoma, when there is tunnel vision, shift to 10-2 for your patient.
Just a couple of points for the residents. If you see cloverleaf field in a uniformed personnel, you are dealing with a malignant. Okay, that's one thing which we have observed in the FIU. And secondly, according to vector and Schefter, the third field is the most reliable. So if you see funny looking scleroderma, you repeat the field. लेकिन अगर field normal है ना, तो उसको repeat करने की जरूरत नहीं है, वो correct है. You don't, I mean that is acceptable. That is acceptable. That's correct. You can repeat a field if it's producing funny looking sclerodermas. कि हो सकता है वो disappear हो जाए. लेकिन अगर visual field normal आ रही है तो that is correct. That is acceptable. ये बड़ी समझने वाली बात है.
Okay, so we move on to our next talk by Dr. Peeswar.
अस्सलाम वालेकुम। किस्मत किया हर एक को कस्साम अज़ल ने। कस्साम अज़ल कौन है? अल्लाह ताला की ज़ात। किस्मत किया हर एक को कस्साम अज़ल ने, यानी हर एक की किस्मत लिख दी। जो शख्स के जिस चीज़ के काबिल नज़र आया, बुलबुल को दिया नाला, परवाने को जलना, गम हमको दिया सबसे जो मुश्किल नज़र आया। तो I'll take you to the next step of diagnostic. Thank you. Diagnostic dilemmas in glaucoma is a regular feature. It is something which is we see and we face every day. Patient पूरी फाइल लेके आपके पास है, उसके बाद पिछले 6 साल के विजुअल फील्ड्स और OCTs हैं और उसको ग्लोकोमा नहीं है और उसका इलाज हो रहा है। एक तरफ ये एक्सट्रीम है, दूसरी तरफ है कि उसको सारी बीमारी है और उसके पास कुछ नहीं है और वो ज़ीरो के तौर पे आपके पास है एंड स्टेज डिजीज़ के साथ। अब आप उसकी सारी चीज़ें करवा भी लेंगे तो क्या कर लेंगे? सिर्फ डॉक्यूमेंटेशन होगी कि इतनी सी टनल रह गई है, OCT सारा रेड हो गया है, सिर्फ डॉक्यूमेंटेशन और आपकी सेफ्टी। अगर आपने उसकी कल को कोई सर्जरी करनी है और पेशेंट के रिश्तेदारों को दिखाने के लिए कि ये नॉर्मल होता है और ये बाबा जी का ये अब नॉर्मल है, यहाँ तक मामले बिगड़ चुके हैं, अब यहाँ से मैंने इलाज शुरू करना, तो अब आप ज़्यादा तवक्कुआत उतनी रखें जितनी कि एक्चुअली होनी चाहिए। तो इन चीज़ों की बहुत सारी वैल्यू है, नॉट ओनली क्लिनिकल बट ऑल्सो फ्रॉम social point of view to explain to the patient and the attendants what is the status of the patient as far as damage of glaucoma is concerned, and also to document for your own safety. तो इसलिए कई इसके एस्पेक्ट्स हैं इसको करवाने के। तो OCT पे हम जाते हैं। अभी यहाँ के बंदे कहाँ अभी सारे? ये प्रेजेंटेशन मैं बहुत दफ़ा कर चुका हूँ पहले भी, इस दफ़ा फिर फरमाइश आई। मैंने विजुअल फील्ड बहुत साल तक पढ़ाई, तो एक दफ़ा मैंने इम्तियाज़ साहब को कहा कि यार बस बहुत हो गई है, एक ही चीज़ बार बार हर कॉन्फ्रेंस में विजुअल फील्ड। तो अब हमें छोड़ के कहीं आगे चलना चाहिए। तो इंसिडेंटली उसके कुछ दिनों के बाद ही FCPS पार्ट 2 का इम्तहान था। तो ऐसा हुआ कि मैं और ये कोई एग्जामिनर है और जो लड़का है उसके पास प्राइमरी ओपन एंगल ग्लाकोमा का लॉन्ग केस है और उस पेशेंट की पूरी फाइल आई हुई है साथ। तो जब उसने हिस्ट्री बता दी तो हमने पूछा भाई इसका अब आप क्या करेंगे? तो कहा जी मैं इसके विजुअल फील्ड कराऊंगा, मैं इसके OCT कराऊंगा। OCT तो उस वक्त इतना नहीं था, पुरानी बात है। तो हमने कहा अच्छा बेटा ये है उसकी विजुअल फील्ड, तो थोड़ा सा हमें बताओ इसमें से क्या देखोगे। वो हज़रत बिल्कुल पैदल हो गए और फारग हो गए। तो ये मुझे फिर कहने लगे कि अब तुम तौबा करो, ये आइंदा से मत कहना कि मैं नहीं पढ़ाऊँगा, क्योंकि अभी भी हालात ख़राब ही हैं। तो वी OCT is the principle of optical coherence tomography, which is based on optical measurement technique called as low coherence interferometry. दो चीज़ों का ग्लाकोमा में जब हम करते हैं तो बेसिकली वी गो फॉर टू एरियाज। वन इज़ दी रेटिनल नर्व फाइबर लेयर एंड सेकंड इज़ दी ऑप्टिक नर्व हेड। ये दोनों का अलग एक्सप्लेनेशन है और अलग इसकी स्टडी है। फर्स्ट आई विल टॉक अबाउट दी RNFL and then we will move on to the optic nerve head, and if time permits I can show you few cases and also talk about anterior segment OCT in relevance to glaucoma depending on how much time is available. फास्ट इसमें जो 4 स्क्रीनिंग प्रोटोकॉल्स आर अवेलेबल, जिस तरह स्ट्रेटजीज़ हैं ना विजुअल फील्ड की कि 30-2, 20-24-2, 10-2, इस तरह इसके भी प्रोटोकॉल्स हैं। फास्ट RNFL थिकनेस 3.4 का मतलब है 3.4 मिलीमीटर अराउंड दी ऑप्टिक डिस्क। RNFL फाइबर्स अराउंड द ऑप्टिक डिस्क आप 3.4 मिलीमीटर। RNFL थिकनेस ये फास्ट है, ये सिंपल RNFL है, ये 3.4 है। उसके बाद RNFL थिकनेस 2.27 इंटू डिस्क, यानी उसके इतने इतने एरिया में करेगा। फिर एक फास्ट RNFL मैप है। नॉर्मेटिव डिस्प्ले फॉर थर्ड एंड फोर्थ आर नॉट अवेलेबल। अब इसका क्या मतलब है? इसका मतलब ये है कि मशीन विजुअल फील्ड के अंदर एक नॉर्मेटिव डाटाबेस डाल दी गई है। इसलिए कहा जाता है कि अगर आपने विजुअल फील्ड करने से पहले पेशेंट की एज एंटर नहीं की तो डोंट एक्सपेक्ट दैट द रिपोर्ट इज़ गोइंग टू बी रिलायबल, बिकॉज मशीन इज़ गोइंग टू कंपेयर द रिपोर्ट ऑफ द पेशेंट विद एज मैच नॉर्मल पॉपुलेशन। इसी तरह इसके अंदर नॉर्मेटिव डिस्प्ले डाला गया है, वो भी उसके अंदर भी क्या क्या प्रॉब्लम्स हैं, अभी मैं थोड़ी देर के बाद उसके ऊपर भी आता हूँ। लेकिन इस वक्त आप सिर्फ ये समझें कि नॉर्मेटिव डिस्प्ले, नॉर्मेटिव डाटा इसके अंदर डाला हुआ है, उसी डाटा से मशीन पेशेंट का डाटा कंपेयर करके आपको रिपोर्ट देती है। तो पहले दो का अवेलेबल है, बाकी दो का अवेलेबल नहीं है, लिहाजा हम पहले दो ही के ऊपर अपनी तवज्जो को फोकस करेंगे। अच्छा, अब RNFL thickness is automatically delineated by the analysis software and it is determined by the difference in distance between vitreoretinal interface and a posterior boundary based on predefined reflectivity signal level। ये तो फिजिक्स है इसकी सारी। मेन चीज़ ये है कि इसकी क्लिनिकल इंटरप्रिटेशन क्या है, वही मेरा आज का मेन फोकस है कि अपने रेजिडेंट्स को और हमारे जो कंसल्टेंट्स हैं उनको थोड़ा सा रिफ्रेशर दे दें ताकि उनकी चीज़ें जहन में रिफ़्रेश हो जाएँ कि जब इसकी रिपोर्ट को देखना है तो इसको कैसे इंटरप्रेट करना। अब जो फास्ट RNFL थिकनेस स्कैन है, इट परफॉर्म 3 सर्कुलर स्कैन्स ऑफ 3.4 डायमीटर अराउंड द ऑप्टिक नर्व हेड विद 256 स्कैन पॉइंट्स। ये इसलिए फास्ट है कि ये 256 को करता है, जबकि जो सिंपल RNFL है वो इससे स्लो है क्योंकि वो डबल पॉइंट्स इससे करता है। 256 प्लस 256 makes 512 points, so it takes double the time in comparison to this one which takes less time. The most commonly used scan type for clinical assessment is fast RNFL thickness map, which is 3.4। अब अगला सवाल ये है कि ये कैसे पता चले कि कौन सी स्ट्रेटजी यूज़ हुई थी, इसमें कौन सी स्ट्रेटजी यूज़ हुई, इसमें कौन सी यूज़ हुई थी। हमारे को रेजिडेंट बताएंगे, रिपोर्ट आपके सामने है, अब आपने देखना है कि स्ट्रेटजी कौन सी यूज़ हुई थी। ज़ाहिर से खारिज करने से नहीं याद आएगा। ये देखिए, ये ऊपर लिखा होता है, ये नहीं ये लिखा हुआ है, देखिए RNFL थिकनेस मैप। रिपोर्ट के ऊपर सब चीज़ें लिखी होती हैं, सिर्फ ध्यान करने की बात है। होता क्या है कि हमारी नज़र जाती सीधी यहाँ, इस पर हमारी नज़र जाती है। जैसे विजुअल फील्ड में हम ग्रे स्केल देखते ही ओहो हो सारा काला हो गया, पता चलता है वो एब्सोल्युटली अनरिलायबल था पेशेंट, बस बटन दबाई जा रहा था अंधाधुंध, तो सारी रिपोर्ट उल्ट पुल्ट आ गई। तो इसके ऊपर भी देख के हम रेड्स को देख के फ़ौरन अलार्म हो जाते हैं, इनको तो कालम होती है ना। हम ऊपर की ये चीज़ें देखते हैं ना, इसके अलावा और चीज़ें देखते हैं जो भी मैं बताऊंगा कि क्या क्या चीज़ें देख के उसके बाद आपने इसके ऊपर आना है एंड पे। जैसे विजुअल फील्ड में आपने जो ऊपर सारा डाटा है पहले वो देखना, 2 सेक्शन हैं ऊपर, उसके बाद आपने साइड पे जो डाटा लिखा हुआ है वो देखना, इसमें सारा क्यूमुलेटिव स्कोर है। ग्रे स्केल तो बहुत में आता है कि काला है कि ग्रे है कि सफ़ेद है, तो इसी तरह आप पहले ये सब चीज़ों को देखेंगे, उसके बाद आगे आएंगे। अब इसके स्टेप्स हैं। पहला स्टेप क्या है, आइडेंटिफाई दी स्कैन टाइप। वो मैं आपको पहले बता दी कि कौन सा स्कैन टाइप यूज़ हुआ है, फास्ट हुआ है कि सिंपल हुआ है, ठीक है, वो उसके ऊपर लिखा है। इसकी इंपॉर्टेंस क्या है, क्यों ये करना ज़रूरी है। वो इसलिए करना ज़रूरी है कि जब आज आपके पास पेशेंट आया, आपने उसको करवाया RNFL थिकनेस में, अगली दफ़ा आप करवा रहे हैं फास्ट, तीसरी दफ़ा फिर आप पुरानी पे जा रहे हैं, तो इससे आपकी रिपोर्टें कभी भी मैच नहीं करेंगी और रिलायबल नहीं होंगी। तो एक ही पेशेंट की बार बार वही स्ट्रेटजी यूज़ की जाए, उसी मशीन पे करवाया जाए, वही ऑपरेटर हो, वही सारी सेंटरिंग करे, वही सारा सिस्टम चलाए, फिर जाके कहीं आपकी रिपोर्टें रिलायबल होंगी और कंपेरेबल होंगी, ठीक है। तो पहला स्टेप ये है कि आप स्ट्रेटजी आइडेंटिफाई करें कि कौन सी है, क्योंकि आपने बार बार वही करवानी है। दूसरा स्टेप क्या है कि ये हो गया, हाँ ये देखें, ये इसके अंदर वो आ गया ना, RNFL थिकनेस मैप आ गया, तो आपको लिहाजा पता चल गया कि आइडेंटिफाई कैसे करना है। उसके बाद अगली चीज़ आ गई OCT इंटरप्रिटेशन स्टेप 2, चेक दी स्कैन क्वालिटी एंड सिग्नल स्ट्रेंथ। जैसे आपने उसमें फॉल्स पॉजिटिव, फॉल्स नेगेटिव और फिक्सेशन लॉसेस देखे थे, ऐसे ही आपने इसकी भी क्वालिटी चेक करनी। और क्वालिटी कैसे चेक होगी? सिग्नल स्ट्रेंथ देख के, राइट की अलहदा, लेफ़्ट की अलहदा, वो भी इसके ऊपर लिखी होती है, ठीक है। तो जब आपके पास सामने रिपोर्ट आती है तो आपका ये देखना बहुत ज़रूरी है कि वो सिग्नल स्ट्रेंथ क्या है, उसका फ़र्क क्या पड़ता है, कम सिग्नल स्ट्रेंथ वर्सेस अच्छी सिग्नल स्ट्रेंथ, दोनों के दरमियान डिफरेंस क्या आएगा, अभी मैं दिखाता हूँ। एक्यूरेट RNFL measurement is impossible if the scan quality is suboptimal. Values of signal strength range from 1 to 10, with 10 represent the strongest and 1 represent the weakest signal. The value of signal strength is directly related to RNFL thickness, and obtaining the maximum possible signal strength is recommended for RNFL measurements. अगर लो सिग्नल स्ट्रेंथ आ रही है ना, तो फिर उसकी साथ एक्सप्लेनेशन होनी ज़रूरी है, उसकी एक्सप्लेनेशन होनी ज़रूरी है। लेंथ ओपेसिटीज़ हैं, कॉर्नियल ओपेसिटी है, विट्रियस एज है, विट्रियस हेमरेज है, कुछ और है। तो लो सिग्नल्स आ रहे हैं, क्यों आ रहे हैं? जब तक आप ये ना समझ लें तब तक आपकी रिपोर्ट अनरिलायबल है, ठीक है। अगर उन सब के साथ रिपोर्ट आई है, फॉर एग्जांपल लेस दैन 5 सिग्नल स्ट्रेंथ आई है, और कोई ना कोई ऐसा फैक्टर मौजूद है जो एक्सप्लेन कर रहा है कि ये 5 क्यों है, तो फिर आप जब अगली दफ़ा भी रिपीट करेंगे तो अगर तो वो फैक्टर ख़त्म हो गया होगा तो सिग्नल स्ट्रेंथ इंप्रूव होनी चाहिए, और अगर वो फैक्टर वहीं का वहीं है तो फिर वो 5 ही होगी। तो आप एक टाइम से दूसरे टाइम पे एटलीस्ट कंपेयर कर सकेंगे कि आज जो थी पेशेंट की कंडीशन, उसी सिग्नल स्ट्रेंथ के साथ 6 महीने बाद क्या कंडीशन है। तो इसलिए ये सिग्नल स्ट्रेंथ इंपॉर्टेंट है। ये देखें, ये भी रिपोर्ट के ऊपर लिखी हुई है, ये राइट आई है, ये जो राइट साइड पे है ये राइट है सारा डाटा, और ये लेफ़्ट है। राइट की सिग्नल स्ट्रेंथ है 9/10 और लेफ़्ट की है 3/10, और आप साथ देख रहे हैं कि जो 9/10 है वो टोटली ग्रीन है, और जो 3/10 है उसमें डिफेक्ट्स आए हैं। अब ये डिफेक्ट्स, ये 3/10 क्यों आए, इसकी कोई ना कोई रीज़न उस पेशेंट की आंख में होनी चाहिए। अगर वो रीज़न मिल गई है तो ठीक है, अगर नहीं मिली तो इसका मतलब है कि आपकी ये रिपोर्ट एटलीस्ट फॉर लेफ़्ट आई रिलायबल नहीं है, ठीक है। अब ये देखिए, ये एग्जांपल है कि उसी पेशेंट का RNFL आप देख रहे हैं, सिग्नल स्ट्रेंथ 5 है तो RNFL थिकनेस क्या निकली है 97 माइक्रोन्स। सिग्नल स्ट्रेंथ 10 है उसी पेशेंट की, तो RNFL क्या निकली है 118 माइक्रोन, यानी कि 21 माइक्रोन का फ़र्क पड़ गया है सिर्फ सिग्नल स्ट्रेंथ की इम्प्रूवमेंट्स। तो उसी पेशेंट का जब आप लो सिग्नल स्ट्रेंथ पे रिपोर्ट को एक्सेप्ट करते हैं, इसका मतलब ये है कि आप गलत रिपोर्ट को एक्सेप्ट कर रहे हैं। या तो उसकी रीज़न है, अगर रीज़न नहीं है तो टेस्ट हैज़ टू बी रिपीटेड विद बेटर एक्यूरेसी, ठीक है। ऑल्दो कि ये टेस्ट उस तरह से पेशेंट डिपेंडेंट नहीं है जिस तरह से विजुअल फील्ड है। मशीन ऑब्जेक्टिवली पेशेंट ने सिर्फ, अच्छा ये अब जो नई मशीनें आ गई हैं उनमें ये मसला हल हो गया, वरना ये वाहिद मशीन है, वाहिद टेस्ट है जिसमें पेशेंट को टेढ़ा देखने को कहा जाता है। अक्सर हम चीज़ों में कहते हैं सामने देखें, ठीक है, इधर देखें। जब आप ऑप्टिक डिस्क देखते हैं कहते हैं जी इधर देखें, तो पेशेंट अपनी आँख को फेरता है तो आपको डिस्क सामने नज़र आ जाती है, डायरेक्ट फंडोस्कोपी में या 90D में। इस टेस्ट में एक स्टार नज़र आता है पेशेंट को फिक्सेशन स्पॉट से हट के, आप उस स्टार की तरफ उसको दिखाते हैं। जो पिछली वर्जन है मशीनों की जो अब आ गई हैं इस साल में, उन्होंने उस टारगेट को स्ट्रेट कर दिया, क्योंकि ये प्रॉब्लम थी, मरीज़ को समझ नहीं आती थी स्टार को किधर देखे। तो जब वो स्टार को पूरी तरह नहीं देखता था तो सारी रिपोर्ट आपकी एक्यूरेसी गलत होनी शुरू हो जाती थी, सिग्नल स्ट्रेंथ ड्रॉप हो जाती थी, सेंटरिंग ड्रॉप हो जाती थी और काम ख़राब हो जाता था। तो अब मशीनें जो नई आ गई हैं उन्होंने बिल्कुल सेंटर में स्ट्रेट कर दिया है कि सीधा इस पॉइंट को देखें, ठीक है। तो अब ये देखें, तीसरा स्टेप क्या है, चेक द स्कैन पोजीशन। एसेंशियल टू पोजीशन द सेंटर ऑफ द स्कैन सर्कल एट द ऑप्टिक डिस्क सेंटर, क्योंकि आपने कहा है 3.4 मिलीमीटर अराउंड द डिस्क। तो अब डिस्क अगर यूँ है तो चारों तरफ बराबर का 3.4 मिलीमीटर होना ज़रूरी है। अगर आपका स्कैन सर्कल ऊपर चला गया तो उसने नीचे का एरिया मिस कर दिया, ऊपर ज़्यादा हो गया, इधर चला गया तो इधर ज़्यादा हो गया, इधर का एरिया मिस कर दिया। अभी मैं तस्वीरें दिखाता हूँ, ये देखें, जो एक्यूरेसी आएगी वो इसकी सेंटरिंग करने से आएगी। ये ऑप्टिक डिस्क है, ये ब्लैक एंड वाइट तस्वीर है, अभी कलर्ड भी आएंगे आपके सामने। इधर देखें, इस फासले को देखें और इस फासले को देखें, इस फासले को देखें और इस फासले को देखें, ये बराबर नहीं है। इसी तरह ये जो ये सर्कल है ये ऊपर शिफ्ट हुआ है, दूसरे में सर्कल नीचे शिफ्ट हुआ है, ये फासला बढ़ गया, ये कम हो गया। तो जब इस तरह से होगा तो 3.4 बराबर नहीं होगा चारों तरफ, तो फिर रिपोर्ट भी आपकी अनरिलायबल हो जाएगी। ये देखें, आइडियल ये है कि चारों तरफ तकरीबन बराबर है, और इस तरह से सर्कल आपका ऊपर निकल गया, साइड पे निकल गया, नीचे निकल गया, तो रिपोर्टें आपकी, ये ग्रीन देखें ये नीचे निकल गया, ब्लू देखें तो वो साइड पे निकल गया, येलो देखें तो वो ऊपर निकल गया, या बराबर है। येलो जो है तकरीबन बराबर है, ब्लू और ग्रीन जो है वो एबनॉर्मल है। चौथा स्टेप क्या है? चौथा स्टेप है कि आपने evaluate the RNFL in quadrant and clock position and wave pattern, ठीक है। Normative database consists of 328 normal subjects fast RNFL के अंदर, ये इन्होंने 328 लिए हैं जिसमें से पूरी दुनिया में से, और उसमें से 8 हैं जो सिर्फ एशियंस हैं। तो ये जो सारी नॉर्मेटिव डेटाबेस है ये एक्चुअली हमारी पॉपुलेशन के लिए नहीं है। हमने अपने डिपार्टमेंट में लाहौर में अल्लामा इकबाल में नॉर्मल पॉपुलेशन के भी स्कैन्स किए हैं, और उसके ऊपर एक FCPA स्टूडेंट को डेजर्टेशन का ये टॉपिक दिया। फिर हमने बच्चों के भी कैलकुलेट किए हैं, लेस दैन 12 ईयर्स का हमारी पॉपुलेशन का नॉर्मल क्या है, ठीक है, और उसमें और इनकी जो डेटाबेस है उसमें थोड़े थोड़े फ़र्क है। एंड वी हैव रिपोर्टेड टू डिफरेंट कंपनीज़ कि इस वक्त जो ये हमने स्टडी की है इसके मुताबिक ये आ रहा है, लेकिन ऑफ कोर्स उनको फिर पूरे एशिया का डाटा चाहिए ना। हमारे कहने पे वो पूरे एशिया का सारा वो चेंज नहीं कर सकते, वो सिर्फ 8 हैं बंदे उसमें। अच्छा, पेशेंट को समझाने के लिए जब मैं ये रंग बिरंगा चार्ट सामने रखता हूँ तो उसको ये कहता हूँ कि इसकी जो कलर कोडिंग है ना वो बिल्कुल वैसे ही है जैसे कि ट्रैफिक लाइट की होती है, कि अगर ये ग्रीन है तो ठीक है, अगर ये येलो है तो बॉर्डर लाइन है, अगर ये रेड है तो उतना एरिया डेड है, उतना एरिया ख़राब हो गया। ख़ास तौर पे ग्लाकोमा की बात हो रही है तो ग्रीन विद इन 5%, 95% ऑफ नॉर्मल डिस्ट्रीब्यूशन, येलो 1% ऑफ 5% ऑफ नॉर्मल डिस्ट्रीब्यूशन, एंड रेड इज़ 1% ऑफ नॉर्मल डिस्ट्रीब्यूशन। इसके अलावा जो कुछ होगा वो एब नॉर्मल होगा। अब ये देखें, ये है जी क्लॉकार, इसमें 12 एरियाज़ हैं, ये क्वाड्रेंटिक है और ये वेव पैटर्न है, ठीक है। इसमें वो इज़न्ट रूल आता है, इन्फीरियर, सुपीरियर, नेज़ल, टेम्पोरल। जो थिकनेस ऑफ द RNFL है वो इस फार्मूले को फॉलो करती है कि ये सुपीरियर, ये नेज़ल, ये इन्फीरियर, ये टेम्पोरल। ये जो नीली लाइन है ये नॉर्मेटिव डेटाबेस, नीली लाइन पेशेंट की है, सॉरी नीली लाइन पेशेंट की है, और ये जो सारा ग्राफ बना हुआ है ग्रीन, येलो और रेड, ये नॉर्मेटिव डेटाबेस है। तो पेशेंट के टेस्ट को उसने उसके ऊपर रख दिया, ऊपर रख के दिखा दिया आपको कि कौन सी चीज़ नॉर्मल है कौन सी एबनॉर्मल है। अब ये देखें कि ये पेशेंट की लाइन यहाँ येलो और रेड जोन को टच कर रही है, उसके अलावा ये सारी ग्रीन या उससे ऊपर जा रही है। लिहाजा ये राइट आई की रिपोर्ट है, ये लेफ़्ट आई की रिपोर्ट है। तो राइट आई में मोरलेस उससे सारा सही है, सिर्फ जहाँ टच किया है उसको उसने येलो दिखा दिया। ये नॉर्मल है क्योंकि ये बड़े पैटर्न्स को देख रहा है, क्लॉकार छोटे एरियाज़ को देख रहा है, और वेव पैटर्न पूरे रेटिना का ओवरऑल आपको पता चल रहा है। लेफ़्ट आई में आप देखें कि पेशेंट की लाइन रेड जोन में काफ़ी ज़्यादा चली गई है, तो उसकी जो क्लॉकार और क्वाड्रेंट है वो भी उसके अंदर है। तो अब पेशेंट को समझाने के लिए सबसे आसान चीज़ ये है जो क्वाड्रेंटिक रिपोर्ट है। आप राइट लेफ़्ट उसको दिखाएं, उसके साथ एक नॉर्मल रिपोर्ट का प्रिंट आउट रखें और उसको दिखाएं जी कि ये नॉर्मल है और ये आपकी रिपोर्ट है, ये राइट है ये लेफ़्ट है ये, और सिग्नल ट्रैफिक सिग्नल की एग्जांपल दे के आप उसको बड़ी आसानी से समझा सकते हैं कि इतने % आपकी ख़राबी हो चुकी है। अगर 2 क्वाड्रेंट उड़ गए हैं जैसे ये उड़ गए हैं तो 50% आपका डैमेज हुआ हुआ है, 50% आपका रिलेटिवली हेल्दी है। तो अब हम जो डैमेज हुआ है वो तो हुआ हुआ है। रेड जो है वेरी रेयरली इट विल रिटर्न टू येलो, ओनली इन 5 to 10% पॉपुलेशन ये रिटर्न टू येलो होगा, वरना ये रेड ही रहेगा। जो येलो है दैट कैन रिटर्न टू ग्रीन इफ़ द ट्रीटमेंट इज़ गिवन, इंट्राऑक्यूलर प्रेशर इज़ परमानेंटली कंट्रोल्ड, न्यूरोट्रोपिक एजेंट्स का जो रोल है वो किया जाए, पेशेंट अपने सारे प्रेशर्स को मॉनिटर करे और उसका ग्लाकोमा टोटली अंडर कंट्रोल हो, तो येलो कैन टर्न टू ग्रीन। आई हैव डॉक्यूमेंट्री एविडेंस ऑफ दिस ऑफ माई ओन पेशेंट्स जिनके येलो ग्रीन में गए हैं। बहुत सारे हैं जिनके नहीं जाते, वो येलो पे खड़े रहते हैं। हम उस पर भी शुक्र अदा करते हैं कि चलो ये यहाँ कहाँ एक जगह पे रुकी तो ये ना बीमारी बढ़ तो नहीं रही ना साल साल। तो ये वही क्वाड्रेंटिक और क्लॉकार। अब एक चीज़ आती है रेड एंड ग्रीन डिजीज़। रेड डिजीज़ ये है कि OCT स्कैन एबनॉर्मल इन द एब्सेंस ऑफ डिजीज़, ठीक है, सेंटरिंग आउट है, सिग्नल स्ट्रेंथ पुअर है, ठीक है, और ये 2 चीज़ों की वजह से स्कैन एबनॉर्मल है, पेशेंट को बीमारी नहीं है। और ग्रीन डिजीज़ ये कि पेशेंट सफरिंग फ्रॉम ग्लोकोमा विद नॉर्मल ओसिटी, ये हाई मायोप्स में, हाई हाइपरोप्स में, चिल्ड्रन में और डिफरेंट रेसेस में जिनका नॉर्मेटिव डाटा नहीं है। तो इनका ये हो सकता है कि मशीन उनको यही समझे कि ये नॉर्मल है, जबकि आप क्लिनिकली जज करते हैं कि प्रेशर भी ज़्यादा है, डिस्क में भी चेंजेस हैं। इसलिए ये कहा जाता है कि ये सब चीज़ें हमारी सपोर्ट के लिए हैं। असल चीज़ हमारा क्लिनिकल एग्जामिनेशन है और पेशेंट की हिस्ट्री है, फैमिली हिस्ट्री है, मायोपिया है, ड्रग्स के यूजेज हैं, डैमेजेस अदरवाइज हैं। उसके अलावा आप जब उसकी सारा एग्जामिनेशन करते हैं तो उसमें आपको इंट्राओकुलर प्रेशर मिलता है, आप उसका एंगल देखते हैं, उसके बाद आप उसकी ऑप्टिक डिस्क देखते हैं और ऑप्टिक डिस्क में भी आपको चेंजेस मिलती हैं। इन सबको मिला के आप एक डायग्नोसिस बनाते हैं और कंफर्मेशन के लिए आप ये विजुअल फील्ड्स और ओसीटी कराते हैं। लेवल ऑफ डैमेज देखने के लिए वो फंक्शनल विजुअल लॉस बताता है, ये स्ट्रक्चरल विजुअल डैमेज बताता है। विजुअल फील्ड जो हैं वो फंक्शनल बताते हैं, ये ओसीटी जो है स्ट्रक्चरल डैमेज बताता है। तो टाइप्स ऑफ आर्टिफैक्ट्स क्या क्या हैं? डिसेंटेड इमेजेस, पेरीपिपिलरी एट्रोफी इन हाई मायोपिया। अब देखें ना, हाई मायोपिया में अक्सर पेरीपिपिलरी एट्रोफी होती है, तो जब वो रिंग उसके ऊपर पड़ेगा तो वो तो बीमारी दिखाएगा ना। तो डिस्क उसकी नॉर्मल है और उसका जो पेरीपिपिलरी एरिया वो एबनॉर्मल है। अल्फा जोन, बीटा जोन, हमें पता है इन सब बातों का। तो वो जोन्स जो हैं वो डैमेज आ रहे हैं, तो जब वो 3.4 उसके गिर्द लेगा तो वो उसको एबनॉर्मल ही लेगा, ठीक है, और आपको रिपोर्ट दे देगा कि एबनॉर्मल है। आपने जज करना है कि क्या चीज़ है। फिर इंस्ट्रूमेंट रिलेटेड है, हेड टिल्ट है पेशेंट की, माइक्रोसेकेंड्स हैं जिनकी वजह से रिपोर्ट ठीक नहीं आ रही। तो समरी ये है मेरी टॉक की कि यू गो स्टेप बाय स्टेप, यू डोंट जंप ऑन द कंक्लूजन जस्ट सीइंग रेड, ठीक है। आप स्टेप 1 देखें कि कौन सी टाइप का है, फिर स्टेप 2 देखें आप कि उसकी रिलायबिलिटी कितनी है, सिग्नल स्ट्रेंथ कितनी है, और स्टेप 3 देखें आप कि जिसमें आपने सेंटरिंग देखनी है कि सेंटरिंग ऑप्टिक डिस्क के गिर्द कितनी है। इसमें आप देखें तो बिल्कुल एक्यूरेट सेंटरिंग हुई हुई। और स्टेप 4 में आप क्लॉकार पैटर्न, क्वाड्रेंटिक पैटर्न एंड वेव फॉर्म पैटर्न देखते हैं। तो ये सब देख के आप अपनी रिपोर्ट को इंटरप्रेट करते हैं। अब ये रह गया ऑप्टिक नर्व हेड एनालिसिस, ये ब्रीफली आपको टच कर देता हूँ। ऑप्टिक डिस्क एनालिसिस कैन बी परफॉर्म विद फास्ट ऑप्टिक नर्व स्कैन, 128 स्कैन पर लाइन, ऑप्टिक नर्व स्कैन 512 स्कैन पर लाइन, 6 इवनली स्पेस्ड लाइन स्कैन सेंटर्ड ओवर द ऑप्टिक नर्व हेड और क्रॉस। यहाँ पे ये ऑप्टिक नर्व हेड है, ये 6 लाइनें स्कैन लगाती है और देखती है कि ऑप्टिक नर्व का और जो ऑप्टिक पिट उसका कप, इन सब के साइजेस क्या हैं और इनके आपस में रिलेशनशिप क्या है। तो ये 6 चीज़ें चेक होती हैं। इंटीग्रेटेड रिम वॉल्यूम, इंटीग्रेटेड रिम विड्थ, डिस्क एरिया, कप एरिया, कप टू डिस्क वर्टिकल हॉरिजॉन्टल रेशोज एंड कप वॉल्यूम। ये 6 चीज़ें, वो 6 लाइनें सारा कुछ करके आपको दे देती हैं इस तरह से। ये इस तरह 6 लाइनें लगती हैं और ये इस तरह से सारा डाटा आ जाता है कि ये चीज़ इतनी है, ये इतनी है, इतनी है। इसकी डायग्नोस्टिक वैल्यू भी है, प्रोग्नोस्टिक वैल्यू भी है कि आज आपने किया, जैसे आप विजुअल फील्ड बार बार करते हैं, तो स्टैंडर्ड प्रैक्टिस ये है कि इन अ कंट्रोल ग्लोकोमा you repeat it after 6 months, and if the red flags are developing very high pace, you then go on for doing it every 3 months just to see कि disease की progress कैसे चल रही है। लेकिन standard practice है every 6 months। हाँ जी, हाँ जी। तो I will just stop here. Artifacts should be taken into account and clinical application.
Disc margins. So I suspected intracranial space occupying lesion. So advise MRI, and this is the MR scan. You can see large lobulated lesion, which MR revealed irregular large 7.3, 6.3, 6.6 centimeter lobulated space occupying lesion with a broad base along the left wing of sphenoid. Lesion showed marked supracellular and cellular extension leading to mass effects upon optic chiasm, ipsilateral cavernous sinus, and significant midline contralateral shift. So appearance of unilateral optic disc swelling with contralateral optic disc atrophy has been described as Foster-Kennedy syndrome. In true Foster-Kennedy syndrome, unilateral disc swelling is caused by a tumor on the inferior surface of frontal lobe compressing optic nerve on one side with swelling contralaterally. In the absence of intracranial mass, these findings are labeled as pseudo-Foster-Kennedy syndrome, typically due to bilateral sequential optic neuritis or anterior optic ischemic optic neuropathy. So Foster-Kennedy is characterized by compression of ipsilateral optic nerve by an intracranial mass often an intracranial fossa, meningioma, frontal lobe, olfactory groove, sphenoid wing. When intracranial mass is large enough, however, to elevate intracranial pressure, contralateral papilledema results, and atrophic optic nerve is no longer able to manifest the optic disc edema, and therefore only contralateral disc swelling manifests. Foster Kennedy is a rare entity, tonnis, found only 22 cases in a series of 3,033 intracranial tumors. So it's very rare. Risk factors are previous radiation exposure to head, neurofibromatosis type 2, female gender, possibly role of hormones, and increased BMI. These are types. So ipsilateral compressive optic atrophy and contralateral papilledema, etiology that is mass. Bilateral papilledema, latron with unilateral optic atrophy, mass. Bilateral papilledema with bilateral atrophy initially and latron, intracranial mass, and unilateral optic atrophy with contralateral papilledema, that is interior ischemic optic neuropathy. Let's skip this slide. So what were the difficulties in this patient? She was 6 months pregnant, okay, so which required multidisciplinary approach. So I referred this patient to neurosurgeon and to the gynecologist. Also anesthesia department was involved, but my concern was vision in this patient, vision in the other eye. After repeated consultation with various consultants and neurosurgeon and gynecologists, the consensus was developed that let's wait for 1 month and let the fetus be viable, and we will operate accordingly. But after 1 month, when the patient came back to my OPD, the vision in the second eye dropped to counting fingers, which initially was 618. So general management, of course, for any meningioma is a surgical resection. But if the patient condition is not allowing you, so the initial treatment of course is symptomatic brain tumor include corticosteroids, which may reduce peritumoral edema and intracranial pressure. If a non-surgical intervention is preferred, stereotactic radiotherapy and radiosurgery can be used in patients. In elders classified greater than 70, stereotactic radiotherapy of benign meningioma could be a favorable option, as neurosurgery can be correlated with some mortality at this age. Radiotherapy works well when the tumor is less than 3 cm, as the dose is 50 to 60 gray, and it may not affect core of the tumor if it is larger than 3 cm. It also depends on type of meningioma. Benign, which is 90 to 95%, radiotherapy is not required. Atypical, only 2 to 3%. If residual tumor, then yes. If no residual tumor, then not required. And malignant, if it's diagnosed on biopsy, then absolutely required. Surgical follow-up. So radiotherapy can be used for residual or recurring tumors post-surgery. Prognosis is variable, depends on patient to patient. This paper is published in Herald. So the take-home messages: when you come across such a patient with decreased vision and headache, so kindly do detailed eye examination. If swollen disc is detected, it prompts further workup, including neurological examination, radiological consultation. Timely diagnosis and early intervention is the key to save patient vision and, of course, life. Thank you.
Thanks, Dr. Asif. It was one of the wonderful case. My question is, what was the size of tumor in this patient? One thing. Second, only limitation in this patient that you didn't go for neurosurgery and waited for 1 month. And the second, I got involved and went to quantic finger vision. So, is it possible we should go for cyber knife or gamma knife surgeries, जो कि आजकल बड़ी कॉमन है और पाकिस्तान में हो रही है, कराची में खास तौर पर जो मैं सुना रेफर भी करते हैं पेशेंट्स को. So, is it possible कि हम उस तरफ जाते, because हमारा प्राइम एम है to save the vision in the other eye, because one eye is gone. So, एक तो ये बताएं कि साइज क्या था. Secondly, जो benign lesions हैं 90 to 95% आपने कहा कि mostly they can cause this situation. So, what if the lesion is benign and it is ordering the compression of the optic nerve? So, can you go for surgery in those cases as well if it is benign as well? क्योंकि वो vein को तो वो कर रहा है, ताकि उसको थोड़ा सा हम debulk करें, ताकि जो optic nerve compression है उसको minimize किया जाए.
Very good question. Actually, I presented this case in my hospital CBC, and we had a marathon discussion Gynecologists were there, neurosurgeon were there, oncologist was there, and anesthesia department was there. First question, size of the tumor was 7.3 into 6.6 centimeters. Yes. The thing is that if the radiotherapy, surgical intervention is required when the tumor is large enough. And in this case, the tumor was of very large size. Okay? So, in this case, I think the radiotherapy will not work. And she was young. She was only 25 years of age. She was pregnant. So, after thorough consultation with various consultants, and she was referred to at least 6 neurosurgeons. And the consensus was developed that let's wait for 1 month. Because the situation was that if you are going for surgery, the problem was for fetus. And it was 6 months, so that was not viable. So it is not a simple case, it was a very challenging case. And a few days back, I just discussed with them, what about the end stage of that pregnancy? Is the fetus viable? So the kid is, mashallah, alhamdulillah, healthy.
What about the vein in the right eye? That was still counterfeiting?
I have never examined this patient again. They are very happy. They are very happy. वो कह रहे हैं कि विजन बड़ी अच्छी है, लेकिन अच्छी है का क्या मतलब है? हो सकता है वो 660 को अच्छी कह रहे हैं, लेकिन इन्होंने दोबारा एग्जामिनेशन नहीं करवाई, बार बुलाया, लेकिन बच्चा भी ठीक है, मदर भी ठीक है, लेकिन कंसेंसस जो हमने उधर डेवलप किया वो ये है कि टाइमली इंटरवेंशन इस पेशेंट में कर लेना चाहिए था, जो अभी पैदा ही नहीं हुआ, ठीक है, जो अभी पैदा ही नहीं हुआ उसके लिए जो ऑलरेडी 25 साल से जिंदा है उसको क्यों मार रहे हैं? 12 जो एंड रिजल्ट अभी मैंने देखा, बच्चा वायबल है, बिल्कुल ठीक ठाक है, कोई हेल्थ इशू नहीं है, तो फिर ये है कि शायद जिन्होंने फैसला किया कि 1 मंथ वेट कर लेना चाहिए वो भी ठीक थे।
So during that 1 month, did you give steroid?
स्टीरॉयड, कॉर्टिकोस्टेरॉयड दिया गया, बिल्कुल।
ठीक हो, चलो।
हो गई।
Thank you, Dr. Asif. Those were the interesting cases. और second case is vitamin D deficiency, irrespective for myopia in children. A cross-section study in a tertiary care center by Dr. Aisha Kaushal.
Bismillahirrahmanirrahim. Thank you, Dr. Good evening, everyone. It's quite late. Everyone is tired. Okay, this is a small study that we conducted. My name is Dr. Aisha Kausar, and the topic is vitamin D deficiency irrespective for myopia in young children. As we all know that refractive error are a common cause of decreased vision in children, and in Pakistan prevalence of myopia is reported to be 3.3%, and its high incidence in children of 5 to 15 years of age. Low incidence of myopia has been reported with more time spent outdoors. So this led to the concept that vitamin D might be a possible mediator in this association. Recent international studies and a meta-analysis reported association of serum 25-hydroxyvitamin D with myopia. Numerically, the numbers were low, vitamin D numbers were low for myopic patients, but this was not statistically significant. However, contradictory references are available. Some say that this is significant. So, the current study was conducted with the objective to investigate the association between prevalence of myopia in children with symptomatic or suspected vitamin D deficiency in 5 to 15 years age children. This was a cross-sectional observational study conducted at Shifa Foundation Community Health Center, and it was a joint venture between ophthalmology and pediatric department. We did a non-probability convenience sampling. Patients of either gender between 5 to 15 years of age with suspected or symptomatic vitamin D deficiency were included, and patients were excluded if they had vitamin D deficiency secondary to renal or hepatic cause, or if they had decreased vision to any other cause other than refractive errors like congenital cataract, glaucoma, surface diseases, and retinal problems. Detailed pediatric history and examination was done. Detailed history about dietary habits, poultry and milk intake, delayed dentition, bone pains, fractures, etc. were taken. History of parental myopia, birth order, time spent outdoor was documented, and a detailed general physical examination was done. Vitamin D deficiency was defined as serum 25 hydroxy vitamin D levels less than 20 nanograms per ml. Detailed ocular history and examination was done, anterior and posterior segment examination, visual acuity, a mean of 3 readings for autorefraction and A scan was taken, and myopia was labeled as spherical equivalent of equal to or less than minus 0.25 diopters. Statistical analysis was done with SPSS version 23. So in our study there were 55% myopic patients and 44.4 were controls. There was no significant difference between in the gender between myopic and control population, as we can see that the p value is 0.792, and literature shows similar results. Now this is an important slide. Here we can see that in our patients myopia had significant association with increased age, height, weight and BMI, these anthropometric measures. And in generally in our population vitamin D levels were quite low. This is for the study cohort. And if you look at the numbers, vitamin D levels were lower in myopic patients as compared to the controls, but this difference was not statistically significant. We compared the various demographic patterns and study and dietary habits of the myopic control population, and we did not find any significant association other than the anthropometric measures that I've already measured, that is BMI and weight and height. We can see it here. BMI of myopic population was relatively better as compared to the non-myopic. Weight centile, there was significant difference. Myopes had better weight centile. Similarly, height centile was better in the myopic population, and that was that's not significant, borderline. However, the parental refractive error as reported in literature had some effect on myopia. We did not find that. Might be the demographic differences can be a cause for this. Birth order did not have any effect on myopia in our population. Similarly, milk intake, egg consumption did not have any effect on myopia in our population. Time spent outdoor, here we can see that majority of our children are not spending enough time outdoor. Majority of both control and myopic population had less than 3 hours of time spent outdoor, and there was no significant difference between the two groups. And as I've mentioned before, our population is generally deficient in vitamin D, the myopic as well as the controls. So, regarding various dietary and lifestyle factors noted in the current study, we did not find any significant association between vitamin D level and dietary and lifestyle factors. Certain epidemiological limitations of this study, being a cross-sectional study, it inherently lacks the effect of temporality. It did not take into account the effect of seasonal variations of vitamin D, and data was collected in a resource-limited condition. So we used the convenient sampling. So I conclude my presentation by that vitamin D levels were lower in myopic children. However, this was not statistically significant. Significant associations were found between myopia and various anthropometric measures, that is weight, height and BMI. And longitudinal studies are warranted to investigate whether high vitamin D concentration is protective against myopia, or is it acting as a proxy for some other biologically effective consequence of sun exposure. The study was published in JPMA. These are the references. Thank you very much.
Dr. Asha, it's one of the concern, and definitely myopia is more prevalent in this part of the world, even more world, particularly after the incidence of COVID. We have seen due to online classes and excessive screen usage, we have seen, I think we were saying 3.3%, I think it's more than 3.3% nowadays. So मैं तो जो भी देखा हूँ क्लिनिक्स में और ओवरऑल हॉस्पिटल में देखते हैं ह्यूज डेटा पीडियाट्रिक एज ग्रुप में I think it's more than 3, maybe you have quoted in some old study. ये हम कंसीडर नहीं करते वैसे डेफिनेटली जो बाकी लाइफस्टाइल मॉडिफिकेशन जैसे ओल्ड एज में हम करते हैं तो बच्चों में भी दे शुड बी इनकरेज कि ये चीज़ें जो है वो आउटडोर एक्टिविटीज सनलाइट एक्सपोजर मिल्क इनटेक आई थिंक जो कि आजकल मैं समझता हूँ अगर है तो वो भी गलत है नाकिस है और अगर ओवरऑल वैसे दे भी रहे हैं उसका सो डेफिनेटली दीज आर द मेजर कंसर्न्स और एक इंपॉर्टेंट चीज़ मेरे लिए एक न्यू चीज़ है विटामिन डी लेवल विद मायोपिया प्रोग्रेशन कि हम इसको डिस्कस नहीं करते पहले सो आपने इन सब बच्चों को विटामिन डी लेवल करवाया जितने भी आपके विटामिन डी लेवल ओके तो आपका लेजर जो था वो पीडियाट्रिक डिपार्टमेंट के साथ चलिए rather than there should be a study जैसे vitamin D and the more important is vitamin A level है मैं पाकिस्तान में मैं चूँकि I wanted to do a study और हमने की भी थी 2 years back अपने गंगाराम हॉस्पिटल लाहौर में उसमें vitamin A level हमने देखे और definitely उसमें थोड़ा सा जो cost effectiveness is a huge vitamin D level सस्ते होते हैं A level एक तो laboratories कम करती हैं और patient जो अफोर्डेबल नहीं होते कुछ आते थे फिर आगे कुछ नहीं बट उसमें हमने देखा था कि जो आपके वो ज़ियोफ्थैल्मियास हमने सिर्फ उनको देखा जो इस तरह के बच्चे जिनमें वो कंजक्टिवल स्पॉट्स आते हैं वाइट और स्पॉट्स आते हैं वो हमने कुछ बच्चों में मिले और हमने उनको वो किया तो डेफिनेटली देयर वाज अ सिग्निफिकेंट नंबर ऑफ किड्स हु हैव लो लेवल ऑफ विटामिन सो ये भी एक मैंने देखा कि मायोपिया इफेक्ट के साथ जनरलाइज्ड स्टडी बेस्ड गहरा कोरिलेशन थैंक यू सो मच सर आई थिंक यू वाज द लास्ट वन सो सर का जो टॉपिक है मेरे लिए जो हम सब के लिए कम्युनिटी आई स्क्रीनिंग विद पीक टेक्नोलॉजी तो PEE के पीक जो है
मैं बताता हूं
वो सर हमें एक्सप्लेन करेंगे सर प्लीज
Thank you very much. My topic is related to preventive ophthalmology. Now, at Hyderabad, we have got SIUBS, that's the picture, Sindh Institute of Ophthalmology and Visual Sciences. So we are doing quite of preventive ophthalmology work in which we are doing screening in the peripheral areas, in the peripheral districts. And that is being done in collaboration of the international NGOs. So they have, previously all the screening programs was used to be done with the manual methods. Everybody, the people who were trained to check the screening, they used to note everything on the paper and a lot of paperwork used to be done. But now this new technology, PEEK, Portable Eye Examination Kit, Portable Eye Examination Kit. This is actually a software which is, inserted in a mobile phone. Then mobile phone is used for the purpose of a screening program. Now, vision and healthcare for everyone. This is a smartphone based vision screening program. This is the app enables non-specialist users. Non-specialist means like our ophthalmic assistants, like lady health workers or even the teachers. They can use it for the purpose of the screenings. In the communities and schools, refer people to care. And the other thing is that it is a real-time data reporting. Whatever we are doing it is immediately going into the record, into the data. So it's a real-time and analytics also. Similarly, at the same time, there is analysis of that. This platform shows live data, so users can see how services are being used and respond to any gap. You can see that lady health visitor, non-specialist user, screens the patients through PEEK application using the Android phone. So now why the need arising? Actually what happened during the first and intense phase of COVID-19, SIUBS, CBM and PEEK initiated. PEEK is a program used by the international NGOs. So with the collaboration of that, they initiated a paperless eye screening project during the year 2020. It connects the primary tertiary level. We are at the SIUBS at the tertiary level. We are in the districts, and then there are primary levels in which there are basic health units, rural health units, taluka hospitals, district headquarters hospitals and the tertiary eye care at SIUBS. And along with that, these hospitals, the school eye health screening, in addition to community eye health screening, same technology has been adopted to screen more than 150,000 school children in the district Matiari, which is a peripheral district. Now that is the patient workflow. How did it work? The health facilities connected through application. There were 24 basic health units, 5 rural health centers, 3 THQs, district eye hospitals and tertiary eye hospital at that. Technology users were 27 Lady Health visitors, they were the screeners, and 7 optometrists, they were the tri-age level. So in the community, the screening was done by Lady Health workers and social organizers, and they got the appointment dates, and then the patient were referred to the basic health units, where community eye health screening was taken place by the Lady Health worker, Lady Health visitors. Lady Health workers, they sensitized in the community, house to house. Then they were taken to the basic health unit, where the Lady Health visitors were there. They screened it. All the people, they were screened by the mobile phone peak technology, and they were referred to the rural health centers, primary health centers, and the refractive services, where they were the optometrists were available, and then they were from there they were referred to the secondary hospital THQs or direct to the tertiary hospital, depending upon the disease process or whatever they've got. They were refractive error people were directly referred. They were not referred to the secondary or tertiary hospital. They were referred to the optical services where they got the glasses. So this was actually patient workflow, and it worked very nicely. Progression. This is the data I'm going to share with you about that. So progress at screen. This is about 7 September. It started 7 September 2020, and data is up to 30th September 2022. Up till now, total patient screening was 164,619, and total patients outcome positive means who have got some ocular pathology. They were the number of the people screened, and the number of the patients which were found, 39%, they had some ocular pathology. So this is the data, and then total patient who were referred from the screening level were 60,545, and the total patient received. Now they were sent to the Taluka hospital, and at the tri-age level, where there optometrists were there. So you can see that out of 60,000, all the patients, they were received at the basic hospital. 96% were the referral case, which is a very, very good. So the patients had the confidence in the system that all of them, they came into there. Then, as I told you that we divided, majority of the patients were the refractive errors and the pathology patients. We separated them. Pathology, patients having pathology, they went to the Taluka hospitals or the tertiary care hospital. Refractive error, they were not sent to the hospital, they were sent to the opticians for the glasses, and they were given the prescribed glasses at the same time, and they were sorted out. So you see, we know that major common problem in the community is the refractive error, and particularly the rural areas, they don't have access to the glasses, and they don't find it. So total glasses, they were prescribed free of cost. The total glasses prescribed 17,052, and out of them this number 18% were prescribed free of cost because they couldn't afford that. Then now the patients who had a pathology, they went to the total patient referred to the THQ and DHQ level, 48,000, and then after that the referral was 5,848 received there. So that is about 72% they were received there in that, and total patient referred tertiary care 913, out of that they were transferred to the tertiary level 380, 42%. As the tertiary care hospital was slightly away, so it was not easy for every patient to come there, so that's why the referral rate is slightly lower here, and it is DHQ and DHQ slightly higher there. So this were the eye conditions which you can see in our community, that The majority of the maximum number was this, which is the conjunctivitis related to it, which is about this amount, and then cataract were 8,059, 13%, 28% was this, and this is the remaining data which you can see about the patients which have got these conditions. So this is how the program is still continuing, running, and we are screening and getting the real-time data, and we have tested this technology, and there is least chance of the error in this because no paperwork. Human error is common in the paperwork. We can make mistakes, some people can do mischief, they can put wrong data, but here there is a real-time data and it is being. So this is a very successful screening program going on. It is continuously and very successfully going on. We have got a future planning for our screening program as well, in which we are going to establish teleophthalmology in the district approach and peak programs in the different Pakistan areas as well. We are going to introduce artificial intelligence. We are planning for that, AI, particularly for the diabetic retinopathy screening programs, and also peak to be made. Now the peak to be made part primary eye care projects in SS and in KSK and other areas as well. They are the parts of the SIN, the different parts of the SIN as well. So what we believe in, that the prevention is better than cure, and now the whole world is going towards the prevention, rather prevent the disease rather than cure, because we cannot cure the patient because we don't have that much human resource, that much logistics available. We have to pay attention to the screening and minimize the disease so that we can serve our community and prevent the blindness. Thank you very much.
So sir, thank you so much for presenting such a good data in DSA. Sir, can you get this technology like any software like this, and which things and which part of the eye during examination this technology can cover? Like NDA segment, posterior segment, fundus?
No. This technology is only for the visual testing. Okay. The mobile phone has got, on the mobile phone screen there are visual acuity charts. Visual acuity chart that is there. So this is only for the visual acuity chart screening, just to identify this patient vision is okay or not. That is for the lady health visitor. They go home to home and also basic animals. Then they identify, okay, this patient vision is less. From there, after that, peak is this software has no function. Then that patient, we have identified that this patient, because then otherwise what we need to do, we need to have a surveillance chart, we need to have a logistics, another we need to have a space, all those things. That is gone now. With a simple mobile phone, you are sitting here, I am showing you this need up to that level, you can identify that, and they can say that the vision is normal or not. If it's not normal, then go through the process.
Lost community के लिए one of the best tools. Secondly, वैसे भी पाकिस्तान में I have seen खास तौर पे villages में लोगों को चाहे हाई मायो को हाइपरमेट को या एस्टिग्मेटिस never wear glasses. This thing कि आप फेस में निकल जाते हैं चीज. Counter finger भी इनके साथ आते हैं, and primarily हम जो OPD में स्क्रीन करते हैं we think it must be a character some organic pathology. जब देखते हैं तो हाई मायो को होता है और जब पूछते हैं कि आप ग्लासेस क्यों नहीं लगाते तो ये ग्लासेस कौन लगाता है कुछ और बता रहे
सबसे सब जो इस प्रोग्राम का फायदा वही है कि हम जो कंसल्टेंट्स हैं वो बड़ी में डेली हमारा इंटरेक्शन होता है. मेजॉरिटी ऑफ द प्रॉब्लम इज इन द आयोपी.
Yes.
क्योंकि उनको पता ही नहीं है. वो आते हैं, वो पेरेंट्स जब आप उनको इन आयोपी समझाते हो बड़े टेंस हो जाते हैं. वो कहते हैं हमें तो बच्चे ने बताया नहीं, तो बच्चा तो छोटा है, आपको कैसे बताया. तो स्क्रीनिंग मेरे ख्याल से मस्ट है.
अर्ली डिटेक्शन ऑफ
वो मैंने वो सिर्फ शुरू में टच किया, मैंने अभी स्कूल स्क्रीनिंग को टच नहीं किया था. ये मैंने डेटा आपको बताया सिर्फ हॉस्पिटल्स का और उसका. स्कूल स्क्रीनिंग में हमने थाउजेंड्स जो वहाँ पे जो भी उस डिस्ट्रिक्ट में स्कूल हैं उसमें अब हमने क्या किया है कि हमने टीचर्स को ट्रेन कर दिया.
हर आने वाली क्लास को पूरी करें.
वो ट्रेन हो गए हैं नाउ.
ये जबरदस्त काम.
बेस्ट.
अब उनको हम उधर नहीं आपको भी टेस्ट भेजने की जरूरत हो एकदम. और दे आर टीचर्स आर सो हैप्पी विद दैट कि उनको एक नई चीज़ आ गई, नया टूल आ गया और दे कैन वो हर जो भी उधर आता है नया चाहिए.
आई सर
सर एड करते हैं इसका thoracic come forward to see the machine.
सर इधर आ जाए ताकि ये बैकग्राउंड
हाँ ये बैकग्राउंड आ जाए ना
सर ये करिए सर आपके पास
मैं सर आपको निकाल
लैपटॉप बंद कर दो पहले
ये सर बड़ा जबरदस्त मुझे बड़ा पसंद आया है।
नीचे
हमारे
कर
दफ्तर
दो।
में तो शिफा में जो स्क्रीनिंग प्रोग्राम है वो मैं शॉर्ट में
हाँ
तो मैंने बोला कि ये स्कूल सिस्टम स्टार्ट करवाने का इन लाइव पे मेन प्रॉब्लम है
Brilliant.
ठीक सर आगे आगे लीजिए सर प्लीज सर कैंसिल वेट सर थैंक यू सर
ठीक है
First action, please come forward. So Dr. Khalid आपको मैं देता हूँ.
आगे आ जाइए सर थैंक यू सर रेडी सर प्लीज सर वेट सर
Thank you sir. हमारा
अब तो
बड़ा
बड़ा-
स्मार्ट सेशन था. हम सिर्फ
अभी
अपने आपस में थे, लेकिन हमें बड़ा मजा आया.
छोटा व्यक्ति अग्रस्त